Good morning, and thank you for the invite to present at the ISICEM 2020. My name is Manu Shankar. I'm an NIHR clinician scientist in the UK. Declarations and conflicts of interest. The research that I'm going to present today is funded by an NIHR Clinician Scientist Award. I do not have any direct conflicts of interest for this talk. The views that I am highlighting are my views, not necessarily of the NHS, the National Institute of Health Research, or the Department of Health and Social Care. So let's think about this. Why are we discussing this topic? We all know that sepsis survivors are at risk for long-term adverse outcomes. Two common adverse outcomes that we understand well are the risk of dying. There is a 15% mortality in patients who recover from sepsis and leave hospital. There is also a 40% chance of unplanned or emergency rehospitalization in the first year following hospital discharge. We also know that patients who recover, or the sepsis survivors, get inconsistent long-term care. The care is not risk-based. In fact, most sepsis survivors do not receive any follow-up care. And I think in this context, we could do better if we knew how best to quantify a sepsis survivor's risk of an adverse outcome like mortality or rehospitalization. When we think about predicting, you look for consistent predictors published in the literature. And I think the two systematic reviews, the first one on long-term mortality in patients who survive sepsis, in roughly 56 odd studies, quite a lot of the characteristics are based on already available data. And same is the case in patients who have unplanned rehospitalization following sepsis. And the predictors with commonly available data could be classified into two groups. One is generic predictors. How old are you? Do you have comorbidities? What's your sex? Is there a previous hospitalization prior to this sepsis admission? And the index sepsis characteristics such as site of infection, how number of organ dysfunction, did you have septic shock, and so on and so forth. And I think the key point here is what these systematic reviews highlight is the data on these predictors are available to every one of us as clinicians and healthcare professionals looking after sepsis survivors even before they get discharged from hospital. And therefore, you can use this freely available information to predict a sepsis survivor's risk of long-term mortality and or unplanned rehospitalization. So in this context, we developed, validated, and assessed the clinical utility of a prognostic score for the outcome of 1 year unplanned rehospitalization or death of adult sepsis survivors. The data will be published online on the 14th of September. Let's look at a brief overview of the study design from this paper. The exposure variable here is patients who survive index sepsis hospitalization, or what you describe as sepsis survivors. These sepsis survivors could be followed up for up to a year, and we did that for up to 365 days. And we looked at two different outcome events, rehospitalization or death by 365 days. The reason for using or is because death is a competing event for rehospitalization, and death could happen with or without rehospitalization. But you got to be alive to be rehospitalized. So that's the reason why we use the composite outcome of rehospitalization or death by 365 days. As I described earlier, the systematic reviews highlight the key predictors that are freely available to most of us as the sepsis survivor leaves hospital. And the goal here was to use these predictors such as age, comorbidity, generic predictors, hospital type, sepsis-specific predictors like site of infection, for example, to see whether we can develop a prediction score or a prognostic score to predict these risks. Let's think a bit more about the study design, the cohort. We used the UK critical care sepsis survivor cohort based on the ICNA case mix program data. We linked the data to the hospital episode statistic data to get the outcome events that are described in the previous slide. The derivation cohort consisted of around 95,000 patients, and the validation cohort consisted of around 25,000 patients. Let's look at the outcome events in these patients. On the figure on the left, figure A is the unplanned rehospitalization or the all-cause rehospitalization events and the infection-related rehospitalization events within that population. What you see here is by 365 days, you got roughly 46.9% of patients have at least one or more all-cause rehospitalization events. The most common rehospitalization reason is infection-related. The figure on the right shows you mortality. The mortality is again stratified by those who get rehospitalized and those who never get rehospitalized. What you see here is the rehospitalization in itself increases your risk of dying, or the death is more common in those patients who have at least one or more rehospitalization. Let's carry on with the development of the prognostic score. We used a logistic regression model for the composite outcome of death or rehospitalization by 365 days. We used stepwise reduction and sequential elimination of predictors. The predictors we eliminated were either complex or did not provide additional value to the score. The goal here was to develop a simple, feasible prognostic score for predicting risk of these two adverse outcomes in sepsis survivors. We started off with 20 predictors and ended up with 8 globally feasible predictors, which I'll come on to in the next slide. Importantly, we did both bootstrap internal validations and limited external validation using the 25,000 patient cohort. So let me introduce you the sepsis survivor prognosis score. This score consists of 8 variables. Variable 1 is any evidence of previous hospitalization in 365 days or the year before the index sepsis admission. How old are you? Older you are, the greater the risk of unplanned rehospitalization or death in the first year. What is your socioeconomic status, or how deprived is your overall socioeconomic strata? Patients with the greatest level of deprivation have a higher risk. Less than lower the kind of socioeconomic strata, greater the risk. Did you have any pre-admission dependence, or how frail were you before hospitalization? The greater the frailty, greater the risk of rehospitalization. Comorbidities. How many comorbidities did you have? One or more comorbidities increase your risk. And there is a dose-response relationship between number of comorbidities and rehospitalization. What type of admission is the current sepsis admission? If you're a medical sepsis admission, for example, somebody with a community-acquired pneumonia, or an emergency admission for an emergency laparotomy for an abdominal peritonitis, you had a greater risk compared to elective planned surgical admission. How low was your blood hemoglobin level at admission? Lower the blood hemoglobin level, greater the risk of rehospitalization or death in the first year. The strata that we got here are the strata used commonly in transfusion. For example, less than 7 patients get transfusion. We feel that blood hemoglobin level is a marker of chronic illness or comorbidity. What was your site of infection at hospitalization due to sepsis? And we gave the neurological site as the base category and compared the other common sites of infection. Now let's look at what happens to the distribution of the prognostic score and the outcomes in these patients. Figure A shows you the distribution. What you see here is a score of 0 to 4 occurs in roughly 17.6%, score of 5 to 6 in 27.1%, and score of 7 or more occurs in nearly 55% of the population. The figure B highlights what is your risk of unplanned rehospitalization or death by 1 year within each of those prognostic strata. What you see here is a dose-response relationship. Increasing score gives you increasing risk of rehospitalization or death, which essentially highlights the value of this kind of prognostic score. Figure 1C shows the performance of the prognostic score with unit change in points, and figure 1D shows the calibration of the prognostic score. There is a linear relationship between the predicted and the observed risk, and the prognostic score highlighted in dot plot on top of it follows that risk. The distribution of the prognostic score is shown on as the bar graphs at the bottom. So in summary, the area under the receiver operator curve for this score is around 0.69. So how would you use this SIP score clinically? And to address this important question, we did a decision curve analysis. A decision curve analysis represents a scenario where you as a treating healthcare professional and patient sit together and understand what is their risk based on this score, and then decide whether they would like to have an intervention that you may provide. And I think an example of this intervention that you may provide would be optimization of their comorbid condition, as an example. And what you see in the graph on the x-axis is the risk of unplanned rehospitalization or death. As you move from the left to right, the certainty of this risk goes up. So the patient may then say, I will choose the intervention that you're providing if my risk is around 50%, as an example. The y-axis provides you with a net benefit. What we think based on our prognostic score is roughly a score greater than or equal to 7 highlights the cutoff at which you as a treating physician or a healthcare professional and or a patient should consider accepting an intervention, despite the uncertainty that you have about the value of that intervention. And I think the decision curve analysis also gives you the scenarios of follow up nobody or follow up everybody. I think follow up nobody is a bad idea. Follow up everybody is a difficult challenge with the healthcare system. And I think a cutoff score of 7 provides you that optimal point at which you choose to look after your sepsis survivors. So, in summary, we have follow up care. We provided score to show that follow up care is based on risk is feasible, and we provide an free online tool that is available in that link. And if you want to discuss with me, you have my email and Twitter account. And the score uses 8 internationally feasible, simple variables. Thank you very much.